And I am your host for this Crisp TV. Dr. Florem is from Heart Center, Lucerne, Switzerland, and we'll be discussing a lot of controversial topics with him. And just prior to this talk, we were all witnessing the lecture by Dr. Kirti Puramia. He's a big believer of laser, and I know that you have an expertise and a big believer of orbital ectorectomy. Having the qualities, the orbital having the qualities of being a single mainstay of expensive debulking devices of all the qualities. What's your thought on that? Laser versus an orbital for an expensive device for debulking strategy?
I have no experience with the laser. I find it an exciting technology, but I have quite a bit of experience with orbital. So in my opinion, orbital is a more controlled way of doing debulking. And I have such a good experience, and we also saw in the other talk how much debulking was possible with orbital. So I think if you are looking for a proven good solution which works quite well and where there is a lot of experience, then I think orbital is the way to go. Now, what we have to also say is this needs time. So orbital atherectomy is not a quick thing. If you're looking for the quick thing, then laser might be the thing you need. But I think if you want to invest some time, and I think we should invest some time in such patients, then orbital is the way to go.
Okay, so the first question is easily answered. Invest time. What's your take on dedicated bifurcation angioplasty? You already told in many of the conferences, many of the lectures yesterday also, that a left main or a non-left main, will the drug-coated balloon change a practice of going holistically for a single stent approach only, ending with a DCB to the side branch concept and putting a stent only if you have a flow-limiting dissection? Do you believe that the long-term MACE rates also will be much lower given the two stents in left main or a non-left main bifurcation PCI?
You know, for all people who claim that PCI is actually quite good, we are doing a great job, then why are we sending so many patients to cardiac surgery? We still send a lot of patients to CABG, either before or after stents. So we are not doing a perfect job yet. So I truly believe that if we want to move a step forward, we have to change something, because in certain indications things don't work. We have lost all trials against cardiac surgeons, all. Not because they are so perfect, but because we are not perfect. So I think in order to become better, we have to change something. And I think in left main, clearly we need to simplify. And it is possible. In my center, we rarely now do two-stent strategy for a left main. And it works very well. Because remember, when you have a problem in left main stenting, you always have it in the ostium of the circumflex. So change there something. Means don't implant a stent. And from the experience we have, and there is also some scientific rationale for that, the results are actually quite good. So avoiding the stent of the ostium of the circumflex by implanting a DCB is fine, because the patient, even, let's say, even if your MLA in the ostium of the circumflex is maybe 4 square millimeters, but that's enough not to cause symptoms. But if you have a restenosis, then the MLA is 0.5 square millimeters. Then you have symptoms, and then you have to do something. And what can you do there in that situation? Then you go and put a second stent or a DCB, but that you can never fix that. And then you send the patient for surgery. So I think two-stent strategy, clearly they take. Don't put two stents if you don't have to.
Perfect. Don't put two stents if you don't have to. And we just saw that we just saw from Dr. A.B. Mehta also that if some rationale by the operator, if he has in mind that the procedure might end up with two stents, it usually end up with two stents. So great. With all the current data allowing us to use drug-coated balloons in small vessels, diffuse diseases, ISR, without extrapolating too much, do we see that future of bifurcation PCI, or for that matter CTO PCI, will reach a stage soon that the stents will only be placed in all the situations where there is a flow limiting dissection?
I think flow limiting dissection and luminal gain. If you have done a PCI but end up without a lumen, then that's not a good PCI. So I think we have to create lumen, and we have to avoid acute complications. Means, you know, a flow limiting dissection, then you need something to do something about it. I think going one step back, we have to solve problems. So in situations where we are doing very well, we don't have to change anything. in situations where we are not doing very well, we have to change something. This means we have to use drug-coated balloons in situations where we know stents fail. And then it probably tolerates even a suboptimal angiographic result with DCB. But proximal LED, 3.5 by 80 millimeter stent, well expanded, that's hard to beat with a DCB. So I think in those situations we still should do DES, and but in a situation long stent, 2.5 by 48 millimeters stent in a patient with diabetes, calcified vessel, yes, we know that stent doesn't have a good outcome, so there we should do something different. And for these situations, I am a propagator of DCB. So I think we have to have a more pragmatic rather than a dogmatic approach.
Absolutely. So the change only what change is needed is what he's saying, that things which are working perfectly fine, we do not need to change it. Okay, so also now is DCB a really important therapy currently available for those kind of patients also who wants to undergo a non-cardiac surgery? For that matter, a renal transplant is awaited, a patient who is opting for a non-cardiac surgery but has found to be a significant coronary artery disease, and these patients are not able to undergo a renal transplant. So for these subset also for the patients who need an early stoppage of dual antiplatelet system, is this DCB a way forward for them?
It is a way for them, and we have good experience with that. There is also published data. In my hospital, we have done this many times that we stopped TAP even before the 1 month. So we stopped sometimes after 1 week because the patient needed urgent surgery. It went well. Because remember, if you don't have a stent, you don't get stent thrombosis.
Yeah, perfect. And the data keeps on getting better and better for complex coronary artery disease. But whether left twin bifurcation or calcific diseases or vis-a-vis favoring angioplasty, but surprisingly, despite the better success rate, despite the better percentage of quality of imaging, the better and safer techniques for CTO recanalization, why do you believe that the recommendations for CTO aren't improving at all, or rather declining?
I think in CTO we have to stop putting so many stents, because the problem we encounter is that in stable PCI it's hard to get prognostic benefit, because also medical therapy works quite well. So I believe there is some benefit if the ischemic territory is large, but that benefit is not very large. So in order not to lose that benefit we gain from improving coronary supply or blood supply to this occluded territory, we have to do our job perfect. Perfect means don't implant too many stents, because by giving the patient the burden of 120 millimeters of stent, we somehow take away some of the benefit we intended to give it to him. So I believe truly that in the future, we also have to take this into account. If you do a CTO of a right, but you end up stenting from top to bottom, the likelihood that artery will be a patent in the next 5 years is not 80-90%. It's probably 20-30%. So I think in those cases we should probably try to reduce the length of the stent. And I know this is not proven very well scientifically, but from our own data we know that for every 10 millimeter of stent we implant, we increase the MACE rate at 1 year by 13%. So probably there is some truth in it. And why did Syntax fail? Yeah, because they implanted. Look at the Syntax patients. They implanted stents like crazy. So we know we can't win the war with stents. So we have to try it without stents.
Cannot win the war with stents. Perfect statement for that. And how did you like the CRISP conference?
Very nice, very interactive. I like the concept that the faculty is heavily involved. So you are not here just to give a talk, but you are here to be interactive. And in the beginning, I was a bit reluctant to be extremely interactive, but then quickly I went into the battle, and people seem to like it. So I think let's do it even more controversial next year.
More controversial, and he's just doing it beautifully today. A rapid fire questions session now. You may choose to answer whichever way you like. Drug coated balloon or a drug coated or a DES in a young STEMI 30 years old.
In STEMI, I'm still pro DS.
Pro DS. DCB or DS in an 85-year-old STEMI?
Clearly pro stent.
Pro stent. Okay, PCI or medical therapy in a stable angina?
PCI if you do a perfect job.
PCI if you perfect job. For in October weather, where do you like more, Switzerland or Mumbai?
Well, Switzerland is a great country, but in India something is better, food.
Something is better, food. Okay, and tea or coffee?
Tea, actually, I don't like coffee at all.
So he's the first person, and we have a first winner today for the tea. And thank you so much. That's all for the quiz PV today. And Dr. Florim, we'll see another person now. Thank you.
Thanks a lot.
Thank you.
Good.